Now, one of the things that you will learn about postoperative fever is that you have to recognize that common things happen commonly. What do I mean by that? There's an old expression that when you hear hoofbeats, you don't think of zebras. What that means is you think of horses, meaning common things happen commonly. Now, you may say, oh, postoperatively a patient develops fever, it's malignant hyperthermia. Oh, sure, it could be that. Is that common? No. Are you going to see it frequently? No. Is it going to be on your test as a frequent thing that they expect you to think of when someone has a fever? No. So again, it's not common malignant hyperthermia. What about a unbelievable gas-forming, sometimes they say flesh-eating bacteria, that causes gas in the tissues, and that could give a fever? Absolutely. But in that situation, that's an uncommon situation. And that is very specifically in a step 3 test situation or my surgical boards that I give. What we're talking about is common causes of fever postoperatively. And you have to know this because remember, when you do rounds in the morning, what do you always ask the nurse? You always ask, what is their temperature now? And you always ask, what is their Tmax, meaning the highest temperature that they had in the past 24 hours. That is very common. That is routine. You will always, when you do rounds, first thing that comes out of your mouth is, what is their temperature now? And what was the highest temperature in the past 24 hours? Okay, listen carefully. On day 1 and 2, day 1 and 2 postoperatively, the most common cause of fever is atelectasis. Atelectasis. What is atelectasis? Collapse of the alveoli. Why does it cause a fever? I don't know. And if you know, you will win the Nobel Prize. But why is atelectasis bad? Test question, life question. Because atelectasis is a prelude to pneumonia. That's so important, I'm going to say it again. Atelectasis is a prelude to pneumonia. Well, now I'm going to ask you a real hard question. Test question and life question. Can you always make the diagnosis of atelectasis? Nope. Nope, you can't. Let's just say that you got a blood count. Can the white count be normal and still have atelectasis? Yes. Can the pulse oximetry still be normal and have atelectasis? Yes. Can the patient look basically okay and still have atelectasis? Yes. Can you get a chest x-ray and can it be normal and still have atelectasis? Yes. The point is, and listen very carefully, that atelectasis is what we call commonly an empiric diagnosis. What does that mean? Empiric diagnosis means using judgment. Using judgment. It's not necessarily objective. An elevated white count, an abnormal pulse oximetry, an abnormal chest x-ray. That's easy. They're not going to test you on that. It's when the patient doesn't have any of that and they have a fever, they can still have atelectasis. So it's a empiric diagnosis. Now listen carefully. You don't want the patient to develop a pneumonia. That's a very bad thing for a patient postoperatively to do. So therefore, you institute something called pulmonary toilet. Pulmonary toilet. Toilet is a French word that means hygiene. And when I am doing rounds with you young colleagues, and I ask you, what are you doing for the atelectasis causing the fever? You will say, pulmonary toilet. There are 4 aspects of pulmonary toilet, which you must know inside out. Number 1, turn, cough, and deep breathe. What does turn, cough, and deep breathe do? Expand the lungs. It expands the lungs. That's number 1. Number 2, chest physiotherapy. When the respiratory therapists come around and pound a little bit on the chest, what does that do? Mobilize secretions. Mobilize secretions. Number 3, incentive spirometry. You know, that little ping pong machine that the patients breathe in. What is that? That's like PEEP, positive pressure. It's like PEEP. And number 4, what do you put in your child's room when they have a cold? You put a humidifier. Humidification, ultrasonic nebulization. What does that do? It keeps the secretions from drying. Let me repeat those 4 things of pulmonary toilet. That's so important. Number 1, turn, cough, and deep breathe. Expands the lung. Number 2, chest physiotherapy mobilizes the secretions. Number 3, incentive spirometry. PEEP. And number 4, ultrasonic nebulization or humidification to keep the secretions from drying. I want to tell you a little story. When I was your age and I was an intern, I know this will sound barbaric to you, but every morning at 4:30, I had to go around to every one of my patients, take a red rubber catheter and put it down their throat so they would cough. The patients hated me. But we didn't have the respiratory therapists that we have nowadays. But those patients coughed and they expanded their lungs and hopefully they didn't get pneumonia. So the most important thing you have to realize that you have to be very aggressive in your pulmonary toilet. And that is the cause of fever in day 1 and 2, most commonly. Now, let's go to day 3, 4, and 5. On day 3, 4, and 5, the most common cause of fever is a urinary tract infection. Day 3, 4, and 5, most common is a urinary tract infection. And what is the most common cause of a urinary tract infection? It is instrumentation, meaning what? A Foley catheter. That doesn't require a lot of brains. Everyone knows that. But even if a patient doesn't have a Foley catheter, the most common cause of urinary tract infection, let me say this, even if someone doesn't have a Foley catheter, still on day 3, 4, and 5, the most common cause of fever is a urinary tract infection. Well, why? I'll tell you why. Test and life questions. When you urinate, how much is left in your bladder? Not much, 10 or 15 cc's. Let me ask you a question. If you urinated and you left 75 cc's or 100 cc's of urine in your bladder, would you get a urinary tract infection? You bet you would. And the cause of that is increased residual volume. Increased residual volume. So you have to ask yourself now, why on day 3, 4, and 5 would a patient have increased residual volume? There's two reasons. There's two reasons. The first reason is, what medications are post-operative patients getting? Narcotics. And what is the side effect of narcotics? Narcotics are anticholinergic. Anticholinergic. We always think about narcotics. The patients always say, "Doctor, I'm constipated." Well, it also affects the bladder. So the first reason that you have a urinary tract infection caused by increased residual volume is the anticholinergic effect of narcotics. Well, what's the second reason of an increased residual volume? Gentlemen and gentlewomen, when you both go to the bathroom and you urinate, you valsalva. Remember what a valsalva is. Your body automatically will contract the abdominal musculature to help with you urinating, whether you're standing up and urinating or whether you're sitting down. If you have an incision right down the middle of your belly, do you think your body will want to valsalva? No. Your body will stop. So therefore, the two reasons why you have an increased residual volume is the anticholinergic effect of that. Let me say that again. The two reasons that you get a urinary tract infection with increased residual volume is, number one, the anticholinergic effect of narcotics, and the second is the difficulty in valsalva if you have an incision going right down the middle of your belly. So now we get to day 6 and 7. Day 6 and 7. What's the most common cause of fever? The answer is wound infection. Wound infection. So you're going to ask me, well, why does it take 6 to 7 days to get a wound infection? I'll tell you. When you take a shower or a bath, do you think you still have bacteria on you when you get out of the shower? You bet you do. You bet you do. But the numbers of bacteria are very low. You are colonized. You are colonized. In order to get an infection, it takes 6 to 7 days for you to get the numbers of bacteria that will make an infection. So in other words, the 7-day, 6 to 7 days, is the time it takes for colonization to infection. That's why, and you might notice this, that surgeons in general, when we see patients post-op, if they're doing well on day 2 or 3, oh, that's great, but we always wait until day 6 or 7. That's why when you do outpatient surgery, you always see a patient 1 week afterwards, because if they're going to get an infection, it's going to be 6 to 7 days. So then the question comes up, test question and life question, how do you determine whether a patient has a wound infection? They have a fever, it's 6 to 7 days. How do you clinically? Well, yes, if you see pus coming out of the wound, that doesn't take a lot of brains. What do we learn about? Erythema, warmth, tenderness, and the most important sign that you have to memorize for the test and life is fluctuance. Fluctuance. What is fluctuance? Squishiness. Squishiness. What is the squishiness? It is pus. And therefore, the treatment of fluctuance from the wound infection is what? It's not antibiotics, it's drainage, drainage, drainage. The number one question I will ask my residents when they have a patient on day 6 or 7, which has a fever, is the wound fluctuant? Because if the wound is fluctuant, the next place you're going is the operating room to drain it. And test question, they may ask you, which should you do, antibiotics or drain it? Drain it, drain it, drain it. Now you may ask, explain that a little bit more. I will. If you have pus and you have fluctuance, you got to get that pus out. If you have a cellulitis, not pus, but a cellulitis, redness, that is treated with antibiotics. But for the test and for life, post-operative fever, day 6 and 7 with fluctuance is drainage. Now, you are all going to ask me, what about DVT? Remember we used to talk about that all the time in terms of fever, thrombophlebitis, and deep venous thrombosis. Why is that not in my discussion of fever? I'll tell you exactly why. Remember we used to say walking, we would talk about wind, water, wound, and then we would include walking. Guys, you can't get a DVT. What do I mean by that? Every surgical patient has to get prophylaxis. That's so important. I'm going to say it again. Every surgical patient must get prophylaxis. There are 2 types of prophylaxis. One type, which is the simplest, is called mechanical prophylaxis. Mechanical. And what does that mean? Generally, sequential compression devices. You may say, well, what about ACE wraps? Or what about TED hose? Guys, there are better things. Sequential compression devices. Those are the devices that squish the muscles to keep the blood flowing. All patients who have surgery, all patients have to have, at a minimum, mechanical prophylaxis. The second type of prophylaxis is called chemoprophylaxis. And that means you give the patient some heparin, not systemic heparin, but subcutaneous heparin, or subcutaneous Lovenox. The bottom line is this, for the test and life, every surgical patient has to be prophylactic, has to be. And in fact, if you don't prophylax that patient, the nurse will call you up and the nurse will say, doctor, don't you want to give some prophylaxis? And if you say no and you don't have a good reason for not doing it, do you know who they will call? They will call me. And I will call you. And I will ask you, why are you not doing this? Why? Because in addition to a DVT causing a fever, the danger of a DVT is causing what? Pulmonary embolus, and that is a very bad thing. So the bottom line is that you just can't get DVTs or or thrombophlebitis post-op. Why? Because you prophylax. And on the test for step 2 and even step 3, they're not going to ask you very specifically. They're just going to make sure that you think about it and prophylax your patients. And in my world of surgery, we commonly, of course, use mechanical prophylaxis, but then we commonly use chemoprophylaxis using the heparin subcutaneously or the Lovenox subcutaneously. So I want you to understand that you must prophylax.